So I'll be talking about a VIP patient who has developed sudden dimness of vision. So these are my disclosures. So the crux of this presentation is that any boost which you or anybody can get as a result of treating a so-called VIP or real VIP should come only as a secondary benefit, reaped only because you have done a job well as a patient's doctor, not as a VIP patient's doctor, but simply a patient's doctor. If you have done your job well as a patient's doctor, there will be dividends. So there can be a VIP, there can be a general patient, but the treatment remains the same. This is, I could have completed my presentation here only. There is no difference. The treatment remains the same. So going forward, what are the causes of retinal causes of sudden decrease in vision? Most dreaded is the retinal detachment. When do you suspect that the patient might have developed a retinal detachment? When you get a call from a patient, a VIP patient who you know is a high myopic, who is complaining of a sudden decrease in vision, some curtains or veil is falling in front of the eye, there is no pain, and the person is saying that in the morning he was able to see in the left side, but now by the afternoon he is not even able to see the left side, it is completely lost. And if he also reports that he had seen some flashes and floaters, and most importantly, if he has also reported some trauma to the eye, he is a politician who has had some election rally and he has some trauma, then and all these symptoms point towards retinal detachment, then what do we do? What we do is to call the patient immediately for a checkup, and thorough indirect ophthalmoscopy is needed. It doesn't matter if you have optos or any ultra-wide fundus photo machine. It's good to have them, but indirect ophthalmoscopy is of utmost importance because it gives you an opportunity to depress and see in 3 dimensions. So many times the breaks which will not be seen without depression will be evident if you depress, do the scleral depression. Obviously, we do the fundus photography and ultrasonography to document, and documentation is equally important in a normal patient and in a VIP patient. Assessing the fitness for surgery is very important, and plan for the surgery. There are scenarios when we can treat the retinal detachment where it is very localized subclinical with laser, but most of the time surgery is needed. What additional do we do for a VIP patient? You will be ready to pick phone calls from unknown numbers. You might be getting so many phone calls regarding this person, and you should be picking the phone calls. At least your secretary should be picking all the phone calls in coming few days. If you're outstation, you cannot say that I'm outstation and I cannot examine you. You need to connect him or her with a colleague who can take care of him or her, and the VIP should get or the patient should get what is needed. Whenever this patient comes to your clinic, you have to say hello before your optometrist does. You should be the first point of contact for that particular VIP, because he will come to you, not to the clinic and not to the hospital if you are working in a multi-specialty or multi-ophthal hospital. So an expedited post-operative visits are needed for such VIP patients. So these are additional things which you will need to do for retinal detachment. Next is CRAO, which is also a retinal cause of sudden loss of vision. Most of these patients have comorbidities, long-standing. It's a painless loss. And the feeling the patient will tell is complete loss of vision. He is not able to see. Sometimes patients come and tell, okay, Dr. Saab, I feel my right eye is closed. Somebody could open my eye and then I can see. He will not even realize that his eye is open and he is not able to see. He feels that the eye is closed. That's the grade of decrease in vision in CRAO. This is not associated with any floaters and flashes. And over a cup of coffee in the morning or a cup of tea in the evening, the patient can say that suddenly after 5 minutes I was not able to see in the left eye, I felt my eye was closed. So this kind of sudden decrease happens in CRAO. What to do in such scenario? Call the patient immediately. Most importantly, if we can say that there is one indication of emergency and early visit in a emergency setup is CRAO. Indirect ophthalmoscopy, fundus photo are routine. Digital massage and paracentesis, as we all know, will work only within first few minutes and hours of the CRAO. Measure the blood pressure, because most of the times these patients are going towards acute myocardial infarction or going to have CVA in coming days or weeks. So measuring the blood pressure at that point of time is very important, because systolics may be in 200s range. Consider pros and cons of surgery, because surgery has lot of pros and lot of less pros and lot of cons in CRAO. Blood investigations are must for every purpose, and for medical legal issues also you need to investigate why CRO has happened, because patients can die after CRO because of other cardiac issues. Prompt cardiological referral is most important, and that's what we can do for this patient. What if this patient was a VIP? Again, you need to be ready to pick phone calls, and you have to connect this patient to your colleague if you're outstation, and you can get a colleague, opthal colleague, to examine him or her, because you are going to tell that Mr. XYZ, you are not going to gain most of your vision. You may gain some vision if you are lucky, but you are mostly going to remain like this. So this is a scenario in a VIP patient is a little difficult. So you may want to ask him or request him to get an opinion, not for the diagnosis part, but for soothing his nerves that what has happened has happened. A phone call to a cardiologist friend is also very important. It can show the concern towards patient, and it can also help the patient tide over any future or near future cardiological issues. Vitreous hemorrhage is another retinal cause of sudden loss of vision. Again, the patient has comorbidities or have had trauma, painless, sudden floating of opacities in front of the vision. Patients sometimes say that, Dr. Saab, I can see red things moving in front of the eye, or black hairs moving in front of the eye. These kind of symptoms also sometimes happen after lifting some very heavy weight or doing some home renovation, and suddenly the patient developed black or red opacities. If the vitreous hemorrhage has happened after Valsalva, there is a possibility that patients might have had a PVD or might need some treatment in the form of if there is some subileum hemorrhage or any retinal break. So the history of Valsalva is very important, and this kind of vitreous hemorrhage usually evolves over days. In the morning, the patient will say that he saw some red spots, some black floaters, and by evening it was complete. So what to do? Call for checkup immediately, blood investigations, explain the course that is going to take time, explain the possible need of surgery. For a VIP patient, you need to assess his lifestyle pattern. They may be stressed. They need to examine. They need to be explained about the flashes, and recovery time will be long if they have a surgery. For CRVO and BRVO or retinal vein occlusions, the symptoms are suddenly not able to read and evolves over days. Again, comorbidities are need to be checked. Blood investigations and explaining of the course of the disease is important. In case of VIP patients, again, he needs to be explained that there may be a need to visit monthly. He needs to cut on his regular work, and he has to visit monthly for intravitreal injections, and obviously need to inquire about the stress and lifestyle pattern of the VIP. So the crux is, the cardinal point side, it is easy to get awed by the VIP status, but we need to stick to the usual standards of treatment for any such patient. A little more chair time will be needed, and you will always be the first contact point for the patient. Can be helpful. Treating a VIP patient can be helpful in many ways in propagating your practice, but do not seek help at the outset to propagate your practice. If it comes, let it come. The tenet of doctor-patient relationships are same for a VIP and for a regular patient. There is no difference. Thank you very much.